Okay.
Okay, which of the following is the most likely cause of the ultrasonogram finding? A 37-year-old primary gravid, 35 weeks of gestation, comes to the physician for routine prenatal visit. She has been receiving prenatal care since 8 weeks of gestation. Pregnancy was complicated by the onset of hypertension at 18 weeks of gestation that has been well controlled with labetalol. Mm, She has an 18-year history of type 1 diabetes mellitus. His hemoglobin A1C is at 8 weeks of gestation was 5.7%. His blood pressure is 140 by 90. Uh, Examination shows soft uterus of a fundal height 32 centimeters. 32 centimeter. The fundal height is 140 per minute. Serum studies blood urine nitrogen is 8 milligram per deciliter. Creatine concentration 1. 24-hour urine collections show protein concentration is 800 milligram. Ultrasonogram shows normal fetus with a fifth percentile for weight. The placenta is anterior and fundal. There is mild there is mild decrease in the amount of the amniotic fluid. There is mild decrease in the amount of amniotic fluid. Which of the following is the most likely? Okay.
Okay. It is placental dysfunction. These patient findings of hypertension, proteinuria, heteroplacental insufficiency are suggestive of preeclampsia. Preeclampsia is caused by abnormality of the placental spiral arteries and poor trophoblastic invasion, leading to placenta hypoperfusion and the subsequent production of vasoactive hormone that cause generalized endothelial dysfunction, hypercoagulability, and vasospasm. Preeclampsia commonly causes uteroplacental insufficiency, placental dysfunction, which in turn leads to fetal growth restriction caused by fetal hypoxia. Fetal growth restriction may be identified by smaller than expected fundal height, a fetus that is below the 10 percentile of weight for its gestational age, and oligohydramnios. The fetus may also have increased head to abdomen circumference ratio in cases of asymmetric fetal growth restriction. Further evaluation with fetal umbilical Doppler ultrasound may indicate fetal hypoperfusion. Okay, next.
Okay. A 57-year-old woman, gravid 3 para 3, comes to the physician because of loss of urine for 2 weeks. She now wears an absorbent pad and frequently soaks the pad. All of her children were delivered vaginally with no complication. 3 years ago she received radiation therapy for cervical cancer and has been cancer free since then. She has no other history of serious illness, takes no medication. Vital signs are within normal limits. Physical examination shows no abnormal genitourinary examination show thin atrophic vaginal mucus. There is pool of fluid in the vaginal canal. Her post-vital residue is less than 10 ml. Which of the following? Urine analysis show no abnormality. Which of the following is the most likely diagnosis? Okay.
Vesicovaginal fistula. Vesicovaginal fistulas can be a consequence of gynecologic surgery, pelvic pathology, or radiation therapy. It occurs when a tract opens between the bladder and the vagina canal and the vagina and results in painless, usually asymptomatic urinary leakage from the vagina. Although it does increase the risk of cystitis from vaginal flora, a genitourinary examination can show a pool of urine in the vagina. The site of fistulization may be too small or difficult to visualize. Confirmatory testing entails infusing dye sterile fluid into the bladder, then evaluating the vagina for the presence of the dye. So you put it in the bladder. The treatment of vesicovaginal fistula involves surgery. It's not overactive bladder is caused by the trousers muscle instability and commonly results in urge incontinence, um, which presents with urge to void, followed by shortly by leakage of urine. Oxybutynin is an antimuscarinic medication used to treat urge incontinence from an overactive bladder and the trouser instability. Overflow incontinence can be caused by underactive or flaccid detrusor muscle or bladder outlet obstruction, resulting in urinary retention, which is evidenced by increased post-void residual bladder volume. When the intravesical hydrostatic pressure eventually overwhelms the internal and external sphincters, the patient will demonstrate passive leakage of fluid. And stress incontinence incontinence that's triggered by increased intra-abdominal pressure. Stress incontinence results from urethral hypermobility caused by pelvic floor weakness or collapse or intrinsic sphincter deficiency. Risk factors, multiple vaginal deliveries, obesity, and surgery. Okay.
A 57-year-old woman, gravitas 6, para 6, comes to the physician 6 months history of immediate loss of urine when she coughs or exercise. Her children were born by vaginal delivery. Her last menstrual period was 10 years ago. She has never received estrogen therapy. Physical examination show normal sized uterus and ovary. There is downward mobility of the urethral vesicle junctions with Valsalva maneuver. Which of the following is most likely diagnosis? Downward Valsalva
Ready?
urethral. Oh yes.
Okay. So stress incontinence, common in multiparous women, multiple pregnancies will result in mechanical stress on the vaginal wall and pelvic floor, can cause weakness of the muscles and connective tissues of the pelvic floor. These weakness in turn compromises the support of pelvic structures, including the uterus, bladder, urethra, and rectum. Increased abdominal pressure like coughing, sneezing, laughing, heavy lifting causes the vesicourethral junction vesicourethral to move out of its normal position, preventing sphincter closure and resulting in subsequent leakage of urine. It is commonly associated with urethral hypermobility as evidenced by deviation greater than 30 degrees from horizontal of an inserted cotton tip applicator with straining. Stress incontinence can also be caused by urethrosil or cystosil, although this will present with additional findings on pelvic exam. The treatment of um, stress incontinence includes pelvic floor muscles and weight loss. Play exercise, sorry, and weight loss with the potential need for pessary device placement or surgical correction if there is persistent incontinence. It is not D or E, uretroprolapse and urethrosil. Oh, it's together. Yeah. Occur when the urethra prolapses through the urethral to the external urethral opening itself or into the anterior vaginal wall. Okay. Respectively, caused by the loss of proximal support. This will also present with stress incontinence, but the urethra will be visible in the external urethral opening or palpable on the vaginal wall on physical exam. Okay, got it. Next.
15-year-old girl brought to the physician because of 1 week history of constant severe abdominal pain. She has 10 episodes of cramps. Each episode lasts 3 to 5 days. She has no history of serious illness, takes no medication, never had menstrual period, sexually active with one male partner. They do not use contraception. She is at 80th percentile of height and weight, temperature 100, pulse 120, respiration 16, PP 90 by 50, hypotension, tachycardia. Okay. Uh, Breast and genital examination tanner stage 5. Abdominal examination show a mass is palpated in the suprapubic region at midline. Pelvic examination, normal appearing external genitalia and lower vaginal. The cervix cannot be visualized because of bluish bulging of the vaginal tissue obscuring the upper vagina. Which of the following? Okay. Is it
Bluish
like
bulging.
hematocolp, like
Bluish
hymenal open is not opened, like
Um,
hematocolpus?
what is the palpated suprapubic region thing?
This one,
Bluish.
bluish bulb, as his menstrual blood is not getting out, it looks like there is bluish bulb.
Oh, they're not even asking for the diagnosis. They're asking for the treatment.
Okay.
Transvaginal incision and drainage. Transverse vaginal septum. Transverse vaginal septum may occur when there is failure of canalization of the vaginal canal, hmm, preventing the excretion of menstrual blood. A transverse vaginal septum presents with primary amenorrhea, cyclic pelvic pain, and bulging pelvic mass in adolescent with otherwise normal. What is that? Vaginal transverse vaginal septum. Significant accumulation of menstrual blood may give the bulging hymen a blue appearance. It may be palpated throughout the rectum. Hmm. A condition known as hematopops. Diagnosis is made by ultrasound. Transverse vaginal septum is treated with transvaginal incision and drainage with a section of the septum and evacuation of the accumulated blood. Transverse vaginal septum. Oh, they're trying to say that there is like a. Okay, okay. I guess that's what they call it. Okay, next.
A 27-year-old woman who is a long distance runner come to the physician because of 1 month history of postcoital spotting. Postcoital spotting. Pains have had regular intervals since menarche. At age 14 years, she underwent bilateral tubal ligation. She underwent bilateral tubal ligation 9 months ago. She is sexually active with a new partner. She is sexually active with a new partner. Which of the following is most likely diagnosis? Regular interval.
I have no idea what is this. Ready?
Okay.
Cervicitis. Acute cervicitis or inflammation of the cervix is most commonly caused by STI, specifically chlamydia or Neisseria. Cervicitis can also be caused by herpes, bacterial vaginosis, and trichomonas, among other infections. It typically presents with postcoital spotting, purulent vaginal discharge, and dyspareunia. Although it may be asymptomatic, physical exam will show mucopurulent cervical discharge, mucopurulent cervical discharge, and punctate hemorrhages of the ectocervix that are friable. Lab studies include NAT testing for chlamydia and Neisseria, as well as testing for bacterial vaginosis and trichomonas. Cervicitis is treated with antibiotics tailored to the underlying pathogen. Chlamydia requires azithromycin or doxycycline in combination with cetiapsone, with the later covering Neisseria. Potential complications are PIT. It's not a blood dyscrasia. Blood dyscrasia may increase the risk of abnormal vaginal or postcoital bleeding. However, this will be less likely than infectious hepatitis in a patient with a new sexual partner and no history of bleeding diathesis. What is bleeding diathesis? Anyway, okay.
Like bleeding disorder.
Bleeding, I'm thinking that's what they mean. Bleeding diathesis. Increased tendency to bleed. Okay, yeah, I guess bleeding disorder.
Okay. How many divine have you heard? Like where from where you are hearing and what are the notes? Like divine.
What do you mean?
Like divine has a podcast, isn't it? Like
Divine intervention. Uh-huh, uh-huh, uh-huh.
so how many have you heard?
I heard all of them.
All of them.
Yeah.
Great.
But I don't think now that I've studied with you and with my study with my tutor, I
Yes.
don't think you need all of them. I think maybe the ethics ones will be, because you are kind of close to your thing. I don't think you can listen to all of them.
No, no.
But
I'm just asking you, like, is it worthy enough, like hearing those things or doing
I
questions?
I think the ethics one and the preventive whatever medicine, those one, the ethics and the patient center whatever thing, I think they are worth it
Okay.
because the exam is a lot of that. Yeah.
Okay.
The other ones, like if you have like you feel like you are maybe like
Oh, like I have, like we have made a concept, so we don't need to hearing those. I feel that
for what for the
for
ethics
all
and the
rest of the subject,
for
apart
the
from
rest.
the
Yeah, I think, yeah, now that I've studied with you, I feel like you don't really need it for, I mean, if you have time, then yeah, and let's say you are weak on cardio and you just want to do the cardio ones, okay, fine, do it. But I don't think you need it. I don't think yeah, I don't think it's needed like that. But definitely the ethics and the patient, whatever, those ethics one, patient
like.
safety.
Uh, can you send me the link of the ethics one?
I
Ethics and
don't
the patient centered.
I don't think there is not the link that you look for it in his I don't know if he has you look for it in his podcast. I don't know if he has a link for it. Podcast topic maybe.
So in here there is everything. Like in
Yeah,
the
it's
okay.
everything. Yeah, it's everything. Maybe it's public health. I think. Um, I think so.
Okay, this one.
No, it was not geriatrics. Um, yeah, maybe from here, like the ethics one. I think he added more. So now it's weird. Okay. But definitely on this thing where it says the public health, it should be there.
Okay,
If you can listen to all the public health, just listen to all just listen to all the public health. No, okay. When you find the biases and stuff like that, don't that's biostats. You already know you don't need to read that one. That's biostats.
okay,
But yeah, yeah. But the ethics and the patient safety and all of that, like it will be clear. Like you will, yeah, like palliative care. You see the things like that. Yeah, if you can listen to them, listen to them.
okay.
Like military, the military one is also good. It's also really good. I think that's all. Yeah. Mm, I think that was it. I'm not sure. I'm not sure. Yeah, I think that was it. So that's step two. I don't think you need a step one.
Okay.
Yeah. 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 Okay. Mm, Why do you feel like you? I don't know if you, because it's so close to your. Okay, I
I'm
guess.
so close to my exam. Yes, that's true.
Yeah, I'm like, do you wanna waste your time on that? Okay, I guess. I guess just. I don't know.
I don't know how.
Maybe just do 1 day.
Sorry.
Maybe just do 1 day. Don't do more. Because I feel like you kind of already know. Like I don't know. I don't feel like it's needed. But I
But
don't want to say I don't feel like it's needed, and then you
no,
just
no.
listen to a few.
No, no. I today I saw a post of Reddit, and then
Mhm,
I just
mhm.
asked you. Like lots
What
of,
did the post say that is needed?
he actually put some of the divine podcast number
Mm-hmm.
to
Mm-hmm.
here. He
Mm-hmm.
also told to do ambush high yield,
Yes.
the
Did you do
200
the
question.
after fire?
Ambush high yield 200 question. No. Do you have ambush?
I
I
think
don't.
it's I
Sorry.
think it's like it's like a free trial. There is like a free trial.
But
I
in
don't.
free trial, you are not able to do those stuffs.
Oh, really?
Yes, in free trial, there is
Oh,
only a
okay.
50 question maybe you can deal with. And they,
Oh,
so don't go for free trials. It will the
oh,
waste of time.
oh my
Even if
God.
even if you apart from going through the free trial, there are like in the Telegram, there are emboss previous question. You can go through that. That was would be enough.
But it's the same. Oh, it's the same questions that are
Yes,
the same
obviously that's the
200.
same question, but it
Oh,
was like it is updating every day, like the URL. They updated nearly 2022. I have seen. So
um,
2024 now. You got my point. Lots
so
of things.
the one on Telegram is 2024 or is 2022?
Sorry.
You say the one on Telegram is 2024 or is 2022?
It is a complicated like in there is 2022, but in
Mhm.
the when you go
No.
deep, it is near about 2029. I can send you the link.
Hmm. Yeah,
Like
send me the link.
emboss
So
cubing.
you don't think it's needed to I need to buy the embos for like a month to for the because I know
If you want to do that, then obviously
but so you think it's the same questions like it's not because if it's the same questions as the telegram as
no
the
question has changed.
oh it has changed no then yeah I'm gonna buy it because I know
You
everybody
got my
says
point.
yeah
Question is
yeah
changing
yeah
every now and
yeah
then,
yeah because
and
I know that embos everybody says to
like
do at ethics.
if you UWorld is present in the Telegram too, but it is
Mm-hmm,
old UWorld.
mm-hmm,
So lots
mm-hmm.
of thing has changed.
No, yeah, I'm gonna buy it because that one for sure, you need it because that amboss. Everybody says that for the last week, just do like those. I don't know if it's 200 or I don't know how many questions you say,
Yes,
whatever.
IL 200. They are talking about IL 200,
Yeah.
and
And
there is some ethics question.
so the IL 200 is just the patient safety, and then there is ethics.
Probably.
Okay. Wait, you say probably you didn't do the Telegram one too?
No, no, I haven't done. I found the link
Oh, oh,
because
you just found the link. Oh,
I
okay.
not just found the link. I have found the link earlier, but I haven't done that because uh, previously I try to do this stuff. Actually,
Mm.
doing offline is not worthy enough like doing
Oh,
online.
really?
Yes,
Oh, why you say that?
because lots of thing has changed. Maybe I think that like doing offline e-world, it will not gonna worthy enough like doing
Yeah,
online.
definitely. You were
Like
definitely.
like
Yeah.
these questions previously what happens in the NBME, they actually do not have the answers. People actually
Ah,
look for the answers. You know the
uh-huh.
there is no clarification, or people actually
Mm-hmm,
use
mm-hmm,
groups to find out the answer. Now it is
mm-hmm.
easy,
Mm.
so
Okay.
they actually uh, have done our work less.
Okay.
But
Okay.
this CMS form, if you bought the CMS form, it will be just a waste of money. I think so, because you can
Yeah,
highlight
yeah, it
here,
is.
you can highlight here, and
It
you
is.
can also highlight there. The explanations are all the same.
Yeah. Yeah. No, the CMS form definitely is a waste of money, but I think the Amboss one
Embossed one
is
is
yeah,
a worthy of money. Yes,
it's worth taking it. You need to do that this weekend. you need to
I will try to. I
you
have.
need to do those because everybody says those mostly for ethics and whatever the patient think. They said yeah, just do those questions. They is more than enough. So yeah, do it.
Okay.
Yeah. Okay.
And 32-year old woman is brought to the a 32-year-old woman is brought to the physician because of 3-year history of irregular menses. Mens has occurred at regular interval, 45 to 60 days interval since menarche at the age of 14 years. But now her cycle interval is up to 90 days. Her menstrual period typically lasts 2 to 7 days. She is otherwise asymptomatic, has no history of serious illness. She has 5 feet 4 inch tall, weight is 103 kg, BMI 39, pulse is 80 per minute, blood pressure 140/80. Physical examination show velvety, pigmented skin over the axilla and the groin. Which of the following serum hormone concentration is most likely to increase?
Where's my pen? Ready? Let's hope
Yes,
it's that. Testosterone.
it's
Uh,
PCOS.
mhm. PCOS presents with regular menses, infertility, and hirsutism, often in patients with increased body weight. It requires two of the following for diagnosis: oligoanovulation, PCOS oligoanovulation, so amenorrhea, polycystic ovaries on ultrasound, and clinical or biochemical signs of hyperandrogenism. It is also associated with signs of insulin resistance, such as acanthosis nigricans, and increased blood glucose concentration. Now, polycystic syndrome is caused by abnormal hypothalamic hormonal feedback response, which leads to increased LH in comparison to FSH, as well as markedly increased androgen testosterone production from the thicker lutein cells. Treatment includes weight loss, OCPs for menstrual regulation, and spironolactone or ketoconazole for resuscitation. Clomiphene stimulates, what was clomiphene again? I knew I was going to forget that. Clomiphene stimulates increased ovulation and can also be utilized for individuals desiring pregnancy as can metformin. If the patient is diagnosed with diabetes, oral anti-hyperglycemic medication or insulin may also be necessary. A potential complication of long-standing PCOS is endometrial cancer caused by prolonged exposure of the endometrium to unopposed estrogen. Okay. It's not age. Cortisol is an increase in Cushing syndrome which presents with fatigue,
Clomiphene
hypertension.
is charm selective
So,
estrogen receptor antagonist at estrogen receptor in the hypothalamus. Selective estrogen receptor modulator.
okay, so it's antagonist in the hypothalamus, so causes increased GnRH, and then that will increase the FSH and LH and cause the pregnancy. Okay, okay. I have to remember that. I don't know why I can't remember those ones. Cortisol is increased in Cushing syndrome, which presents with fatigue, hypertension, focal obesity, hyperglycemia, fat distribution, abdominals. Is less likely than PCOS in the setting of chronic abdominal uterine bleeding and obesity. Okay, next.
Okay. A, a 27-year a 27-year-old woman gravida 2 para 1 aborta 1 comes to the physician because of 3-day history of increasing abdominal pain and a 1 day of fever. 1 day of fever. 5 days ago, she underwent an uncomplicated abortion at 10 weeks of gestation and received prophylactic antibiotic. She received 102-degree Fahrenheit pulse, 110 per minute, respiration 24 per minute, blood pressure 90 by 50. Physical examination shows a tender uterus consistent in size with 12 weeks of gestation, no adnexal masses. Pelvic examination. Pelvic ultrasonography shows a heterogeneous endometrial mass, and IV antibiotic therapy is she underwent suction and curettage. By a sharp curettage remove the infected material, which of the following increased risk.
Ready?
Yes.
Is amenorrhea. Spontaneous or induced abortions can be complicated by septic abortion or sepsis if there is superinfection of retained products of conception in the uterus. Patients can present with fever, abdominal pain, foul smelling vaginal discharge, tachycardia, hypotension. Treatment includes broad spectrum IV antibiotics and prompt surgical evacuation of the uterus with dilation and curettage. Dilation and curettage of the uterus increases the risk of Ashmer syndrome, which refers to development of intrauterine synechia and intrauterine scar tissue formation following damage to the endometrial basal layer. Asherman syndrome is characterized by hypomenorrhea, amenorrhea, cyclic pain, infertility, spontaneous abortion. Diagnosis can be made by saline infusion, sonohysterogram, hysterosalpingogram, or hysteroscopy, and treatment involves the lysis of synechia and hormonal therapy to restore endometrium. Okay, next.
A 19-year-old woman comes to the emergency department because of moderate lower abdominal pain and vaginal spotting that began after her last menstrual period 2 weeks ago. Mens occur at 28 days interval. She underwent first trimester electrical lab abortion 8 months ago, and she has been using oral contraceptive pills. Then she has been sexually active with one male partner for 1 year. Her temperature is 37. Vital signs are within normal limit. Abdominal examination shows no tenderness. Pelvic examination shows blood tinged discharge at the cervical os. There is cervical motion and mild uterine tenderness. Uterine pregnancy is negative. Which of the following is the most likely diagnosis?
Hmm. Abortion. Are we using
Laura,
OCPs? One male partner for 1 year. Butt-in discharge, uterine motion, and my uterine tenderness. I am in between chlamydia and trichomonas, but chlamydia trichomona wouldn't show fever.
and they will not gonna come with blood tinged discharge, isn't it?
Blood tinge, that is true. But retained products of consensual will have fever and abnormal vaginal
The
discharge.
elective abortion done 8 months ago.
Oh, 8 months. Oh, sorry, I
Yes,
thought 8 weeks.
8 months is a very
Yeah, it's very long. Sorry, no, it's not. It's not retained for okay. I thought it was. Yeah, yeah, it's not. Then is the OCP. I don't know, but menses occur at normal intervals.
so it is
Uh,
not.
it's not the OCP. Then what are we left with? The polyp.
No, it's not poly.
It's not polyp, and there is blood thing. It's one of the things.
STD, yes.
It's one of the STDs. Shows, and then the cervical blood tinge, blah blah blah. Does chlamydia cause cervicitis, or is
Yes,
it a
yes,
chlamydia?
can cause.
Okay, okay, yeah. Okay, that was a bit complicated. Okay, PID. Oh, she has PID. Characterized, but she don't have no fever and nothing. Characterized by inflammation of the upper genital tract and pelvis from upward migration of bacterial infection from the lower genital tract. Its clinical manifestation include abnormal uterine bleeding, cervical and vaginal discharge. Okay, cervical motion tenderness, uterine tenderness. Chlamydia is a common cause of PID when the uterine lining is the only portion of the pelvic viscera involved. It's synonymous with endometritis. However, endometritis may also be idiopathic in nature or caused by foreign bodies such as intrauterine device. Chlamydia is common STI in young adults. In fact, testing for chlamydia as well as Neisseria recommended by USPSTF for all sexually active patients under 25. Chlamydia infection may present with urethritis, dysuria, vaginal discharge. Okay, vaginal discharge. However, it can also be asymptomatic. Diagnosis is made by NAT, and treatment consists as azithromycin, doxycycline, ceftriaxone for Neisseria. When the infection has caused endometritis indicated by uterine tenderness or physical exam, 10 to 14 days of antibiotic is recommended. And it's not trichomonas, it's STI that causes vaginitis and cervicitis in women and urethritis in men. It's caused by trichomonas, anaerobic flagellated protozoa. Trichomoniasis present with pruritus, so itchiness, dyspareunia, cervical erythema, an abnormal discharge that is described as green, frothy, and malodorous. Okay, so remember that chlamydia can also have blood tinge sputum.
Vaginal discharge.
Blood tinge, yeah, sorry, vaginal discharge.
A 17-year-old primary gravid patient comes to the physician because of decreased fetal movement. Because she has decreased fetal movement over the past 2 days. She does not recall the date of her last menstrual period and had only previous prenatal visit. Examination shows a uterus consistent in size of 32 weeks of gestation. Ultrasonography shows a biparietal diameter consistent with 31 weeks of gestation. There is a duodenal bubble and flaccid tone on the fetus. There is a duodenal bubble and flaccid tone on the fetus. Which of the following is the most likely cause of this patient finding?
Duodenal bubble. Okay, I'm thinking it's that one. I only think that sounds
Okay.
okay. It's down. Trisomy 21 is a chromosomal disorder most commonly caused by meiosis non-disjunction, although it can also be caused by imbalance of Bessonian translocation and post-fertilization error in mitosis. It's the most common chromosomal trisomy that results in a viable birth. Symptoms and signs include hypotonia, downturned palpable features, prominent epicanthal folds, flat faces, single palmar creases, and intellectual disability. It's also associated with congenital malformation, just such as atrioventricular septal defects, duodenal atresia, H-Bron disease, and increased risk for ALL and dementia, Alzheimer type. Where am I? Risk factors include advanced maternal age and previous child with Down syndrome. Diagnosis is typically made prenatally with routine screening ultrasound showing increased nuchal thickness or increased beta hCG and inhibin A with decreased alpha fetoprotein and STO concentration in the second trimester quadruple screen. It is not, what was that again? Turner syndrome uh, is a common cause of primary amenorrhea, but also presents with absence of secondary sexual characteristic. Short status, cystic hygroma, wetness, swelling on the hands and feet, quadration of the outer bicuspid valve, skin is not associated with duodenal atresia. And it's not fetal growth restrict. Nah, I don't need to read that one. Okay.
Okay. A 34-year-old woman gravida for para 340 weeks of gestation, gravida for para 340 weeks of gestation is admitted because of blood pressure 160 by 95. She has chronic hypertension and is being treated with methyl dope. Ultrasonograph shows fetal growth restrictions. 4 hours after induction of the liver with oxytocin, the cervix is 4 hours later, the cervix is 6 centimeter dilated. A fetal heart tracing is shown. Which of the following is the most commonly explanation findings in this patient's heart tracing?
What is that?
Deceleration.
Variable deceleration. I forgot the mnemonic. Oh my god, that's why I hate mnemonics.
Uh,
It was veal, variable, veal chop. Ah,
cord complex oligohydramnios cord prolapse.
core, core, core compression, right? Veal is variable. Oh, Jesus.
Variable deceleration.
I completely forgot the mnemonic.
This
What was the mnemonic? It's veal chop. V is oh my god. Never mind. I completely. That's why I know when I get nervous, like the money just leaves my head. There's no point of me.
It is late deceleration. There is
It's oh, it's late deceleration, so it's L. So it will be P. So it will be P. So uteroplacental insufficiency or no?
yes.
Okay. Oh my God.
Early deceleration, I think so. It is cock like cord compression, oligohydramnios, and cord prolapse.
Bill chop. So early
Where is the
deceleration.
mnemonic? Veal chops.
You never heard that one?
No.
I thought you. Oh, I thought it's like Bill chop or it's Vito Harry. Yeah, I guess Vito Harry. Yeah, that one.
Okay.
Variable deceleration is core compression. Early deceleration is head compression. Acceleration, good oxygen is good, and late deceleration is placental insufficiency.
Okay. Veal chops.
Bill chop.
Variable deceleration is cord compression. Early deceleration is head compression. Acceleration is oxygen good, and late deceleration is uteroplacental insufficiency.
Placental insufficiency. Okay. Yeah, I got that one wrong. Where is it? Okay, the placental insufficiency. Uh, and fetal hypoxemia can present with late deceleration. In the fetal heart racing, I need to review these things. Late decelerations are defined as gradual decrease in fetal heart rate that begin after the peak of uterine contraction and that reach the nadir more than 30 seconds after the initiation of the heart rate decline. Risk factors for development of placental hypertension, diabetes, anemia, cocaine, smoking, or coagulopathies, latent pregnancy, where am I? Uterine infection, fetal hypoxemia can also be caused by severe uterine contractions and maternal hypotension hypoxia. Treatment consists of supplemental oxygen, movement of the patient onto the left side or onto all fours, and IV fluids. If late deceleration persists, and fetal heart rate tracings, or if it persists, then an urgent C-section is indicated and continued placental insufficiency and fetal hypoxemia will result in death on the fetus.
Okay.
Okay.
Oh, a 22-year-old woman comes to the physician because of 2 week history of increasingly severe burning of vaginal burning and discharge. Increasingly severe vaginal burning and discharge. She has she has been sexually active with one partner for a year. And they use condoms consistently for contraception. Examination shows normal external genitalia and a gray frothy vaginal discharge. Normal external genitalia, gray frothy vaginal discharge. The pH of the vaginal discharge is 5. Microscopic examination shows small epithelial cell coated with bacteria. Which of the following is the most likely?
Ready?
Is it? It is bacterial vaginosis, isn't it?
I think so.
Okay. Okay.
Okay, here.
I can see your
Bacterial
screen
vaginosis
again.
is common gynecologic condition characterized by
Can
shift.
you hear me? Okay, now.
Oh my God, let me start this one. Yeah, can you hear me?
Yes, I can hear you. I can
Can
see
you
your.
hear me?
Yes, yes, I can hear you. I can see your screen now.
Okay.
Okay.
Bacterial vaginosis is a common gynecologic condition
It
characterized by
never
shift.
happened with us. I don't know what
Yeah,
happened with them.
that's weird. I don't know. Common
Complain,
gynecological.
complain the team.
Yeah, definitely. It's probably teams.
It's team's
Mhm.
fault because our network is quite good. You and
Yeah.
yes, okay,
Characterized by shift of vaginal flora and overgrowth of a particular bacterial species, most commonly Gardnerella vaginalis. Gram variable facultative anaerobe bacterial vaginosis present with gray thin malodorous vaginal discharge. pH is increased over 4.5 and fishy odor is detected on pH testing. Identification of clue cells on wet mount preparation is diagnostic. Metronidazole is the first line therapy, which may be applied vaginal as a vaginal gel. Bacterial vaginosis is not considered a STI, and treatment of asymptomatic sexual partners is not recommended. Okay.
okay. A 23-year-old primary gravid woman at 33 weeks of gestation is admitted to the hospital because felt she has not felt fetal movement for the past 2 days. Pregnancy has been uncomplicated. She has no history of severe. She has no history of serious illness. Her sister had three spontaneous abortion. Temperature is normal. Pulse normal. BP 110/60. Examination shows soft uterus consistent with 33 weeks of gestation. Fundal height is 34. Fetal heart tone cannot be auscultated. Ultrasonography confirms the intrauterine fetal demise. Lab lab findings show the to be homozygote for the factor V ligand mutation. Thrombosis of which of the following show fetal demise? Factor V ligand.
Is it the umbilical cord or is it the ureteroplacental artery? I don't think the cord. Anyway, ready?
Okay.
Uteroplacental artery. Okay. This patient presents with uteroplacental artery thrombosis caused by factor V Leiden, autosomal dominant condition, or it's dominant, or where coagulation factor V is resistant to inactivation by protein C, leading to hypercoagulable state. This hypercoagulable state creates an increased risk of thromboembolic events in the maternal vasculature, including within the uteroplacental arteries, okay, leading to placental infarction and possible intraenteral fetal demise, as well as maternal DVT of the pelvis and lower extremity. Thromboembolism is most likely to occur within the maternal vasculature and affect the uteroplacental arteries. The relationship between maternal factor V Leiden and fetal vascular thromboembolic disease is less clear unless the fetus has also inherited the mutant allele. Okay, so it's not D because umbilical cord. Thrombosis is also an unlikely source of placental infarction, given that it is within the fetal rather than maternal circulation. Okay, that's true, makes sense. While red, it most commonly affects the umbilical vein and may occur following chordocentesis. I don't know what chordocentesis means. Okay,
Okay. Next. An 18-year-old primary gravid woman, 39 weeks of gestation, delivers a newborn boy after developing chickenpox, and the pregnancy had been otherwise complicated. Which of the following is the most appropriate therapy?
for the baby.
Newborn.
Newborn. Ah, what's the difference between immune globulin therapy and varicella zoster immune globulin therapy? I don't know. Oh, why is it doing this?
Okay.
Okay, so it's VZV therapy, immune globulin therapy. Primary infection with VZV. Oh, primary infection with varicella zoster virus manifests as chickenpox. Maternal varicella carries a high risk of vertical transmission, both in utero and perinatally. Infections in early stages of pregnancy can lead to congenital varicella syndrome, which is characterized by severe birth defects, including microcephaly, uh, intracranial calcifications, cerebral cortical atrophy, intellectual disease, seizures, limb hypoplasia, cicatrizing skin lesion, and ocular defects such as microphthalmia and cataracts, chorioretinitis. Infections in the perinatal period can lead to neonatal varicella, which can present with fever, generalized vesicular rash, and in severe cases, organ involvement, meningoencephalitis, pneumonia, and hepatitis. Newborns of mothers affected by varicella should be given post-exposure prophylaxis with the varicella zoster immune globulin therapy. Is not a observation for signs of infection is inappropriate in this case. Treatment with immunoglobulin can reduce the severity of neonatal varicella and can prevent neonatal acquisition of the disease. Treatment prevents serious of or fatal neonatal complication. It's not that cyclovir therapy is indicated once neonatal varicella symptoms clinically manifest. It's not part of the routine post-exposure prophylaxis. It's not immune globulin therapy is an acceptable alternative to varicella zoster immune globulin, but only if the latter preferred treatment is unavailable. Okay.
So, what is the take home of the previous question?
Um, I only got this question right because I just read the thing you sent me. I just read it yesterday. Remember that post-exposure prophylaxis thingy? So I just read it yesterday, and that's how I remember. It was one for varicella. This one. Um, what was it? Immunized patient exposed. No, you should receive. No, there was this one neonatal varicella. Oh, if they already have varicella, you give acyclovir. However, infants less than 1 year old do not receive post-exposure prophylaxis. So less than 1 year old. Neonatal exposure to herpes and varicella is extremely dangerous.
So they
Infection
are
can
talking
disable.
about, oh, okay. If it is okay, what is post-exposure prophylaxis for varicella in a pregnant patient? That doesn't make sense according to this.
No, this I think it's this one. What is post-exposure prophylaxis varicella for a neonate? IVIG. Infants aged less than 1 year outside of the neonatal period. So if they are 1 year but they are not neonate, are not eligible for PCV vaccine and do not require immunoglobulin. So if this infant was like more than 30 days, you will just do you wouldn't give none you would not give the immunoglobulin, you will not give the vaccine. Um, yeah, so you don't give any of those. But because this infant on the question is a newborn, so he's inside the neonatal period, that's why you give IVIG. So it says here now infants less than 1 year. Um, so over the 30 days or more than 30 days, you give nothing. You just do supportive care. Uh, unless they are neonate, which that's when you give them immunoglobulin. Does it make sense when you read those ones?
Okay.
Yeah, it's just that I just remember because I just read that yesterday, so that's how I remember it.
Okay. Let's take a break. Then we can
Okay,
start. Okay.
okay.